Dr. Ferhan is a clinician from the UK, multi-qualified doctors that teach and mentors within the field of dental implants and surgical dentistry.
What an absolute pleasure it is to be invited to share my experience and understanding around full arch, and specifically around a very specific topic within full arch. And again, thank you very much for the invite and the kind introduction. Sergio gave a very kind introduction. I am a private practitioner. I have a focus very much exclusively to dental implants, very much around immediate load. And the vast majority of my time is spent in education and training and mentoring other colleagues. And that's really where my passion lies, and where my love for using the Neodent GM system has been born from. And I'm just overwhelmed that I can now share this with colleagues. And the question I was posed is, why use long implants? And it's a very, very good question, and a question that comes up a lot, not just when we're talking about full arch implant dentistry, but conventional implant dentistry. But today we will focus on full arch rehabilitation, and specifically immediate loading, something that is dear to my heart. So why place longer implants? Well, it allows us to immediately load. And a lot of the big studies that the foundation of full arch immediate load was built on utilized implants that were 10 millimeters and greater in length. Placing longer implants allows us to engage the best quality bone. It allows us to get bicortical fixation. It allows us to engage areas that we may not be able to reach with shorter implants, such as the pterygoid region, such as the nasal bone region, and as my colleague will speak afterwards, the zygomatic bone. The use of long implants may avoid more complex solutions, like bone grafting. And ultimately, what this does is reduces the morbidity and expedites the treatment process for our patients. And that's what we want as clinicians. And so today I'm going to discuss the rationale for long implants and upper arch rehabilitation, just touch upon trans-sinus and pterygoid implants. I'd like you to start to understand a bit about the rationale, why we would use these implants, and I'm going to introduce you to the surgical protocol. So what is it in the maxilla that really challenges us as clinicians to be able to deliver immediate load? Well, often there's inadequate bone volume. And that's often due to age changes, causing alveolar bone resorption, and following the loss of teeth, we get maxillary sinus pneumatization or enlargement. And for all of us that know, that have worked in the maxilla before, know that the quality of bone can be challenging to deal with. It can be often D3, D4, fatty bone. And even when we try to raise the flap, we often find that our instrument causes an indentation into the bone. Now, here's a little table illustrating zoning of the maxilla as described by Ed Bedrosian, where he talks about zones 1, 2, and 3. Zone 1 is canine to canine region in the maxilla. Zone 2 is the premolar or bicuspid region. And zone 3 is the molar region. And this table illustrates potential treatment options for patients based on bone availability. And in today's lecture, we are going to focus on those patients that have limited bone. And when I talk about limited bone, moderate to severe atrophy of the maxilla, bone limited to zone 1, i.e. canine to canine region. And it's these patients that we have to look to utilize a full range of implant techniques, axial, trans-sinus, pterygoid, and zygomatic. And this is the beauty of the Neodent GM Helix system, because it allows me to do that. Some of the indications, as I said, we're not using the Trans-Sinus, the pterygoid implant as a single standalone restoration. It is part of a full arch rehabilitation. And I must add, it's part of a fixed full arch rehabilitation. In my experience, I would not be comfortable doing a overdenture on the caters in the maxilla. So we're very much talking about fixed full arch rehabilitation. So some of the indications, so moderate to severe maxillary atrophy, we're looking to avoid bone grafting, and the big one here, eliminate cantilevers because of the mechanical and biological complications that may arise from this. So what is a trans-sinus implant? Well, it's an implant that's placed posteriorly, angled forward, passing trans-sinus, so through the sinus. And apically, it fixes to the lateral piriform rim into the lateral nasal wall. And this image has kindly been allowed by my colleagues in Italy, Dr. Ferraris, Dr. Nicoli, and it illustrates nicely an image of a trans-sinus implant. And with their research, they speak about grafting and non-grafting in the sinus to help support the implant, depending on the amount of alveolar bone available. And here in the image on the right, on the patient's right, on the skull, you can see if you have 1 to 3 millimeters of alveolar bone, then the protocol states that we're looking to graft into the sinus to support the implant. But if there's over 3 millimeters of alveolar bone, then we're looking to not need to graft and avoid the morbidity and the additional cost to the patient. So let me introduce you to this picture. This was a patient I treated 2.5 years ago, a failing upper dentition, multiple failing restorations, and the patient came to me. They were referred to my clinic for a fixed arch solution. Here is another image. And although this is a 2D image of a CBCT scan, I think it shows nicely that there is an enlarged right and left maxillary sinus. So here I'm illustrating the right sinus border, the medial wall, the left, the nasal floor, and very much the bone in zone 1. And in zone 2, I can angle an implant on the right side. On the left side, it's limited. So I just want to illustrate in the next image the x-ray that was taken 2 years post-treatment, just to start to introduce you, one, to the GM Helix and the treatment options or the treatment implant types that I can deliver to rehabilitate a full arch. So here is the final restoration 2 years down the line, where on the right side you can see a pterygoid implant placed. We've got conventional straight and axial implants. On the upper left side, we've got a trans-sinus implant. And here in red, I have illustrated how I've augmented the left maxillary sinus to give that implant a bit more support. On the day of surgery, this patient was immediately loaded, and this is the final restoration. And I've been able to deliver something that's fixed, that there's no cantilevers, and we've restored with 6 implants in the upper arch. And this gives me confidence that long-term, this patient is going to not require additional treatment. So what is it in the design features that allow us to utilize the GM Helix long to do trans-sinus placement? One, it's tapered, critical to get stability and engage the cortical bone to get that stability to allow me to immediate load. It's got an aggressive thread design. We have lengths of a variety of lengths, because often we're placing 18, 22 and a half. So it goes up in a nice stepwise gradation. There's various diameters depending on the bone availability at the crest. And this one, which I love, there's prosthetic flexibility. One platform and multiple options for multi-units. So at present, 0, 17, 30, 45 degree angle correction, one platform. Beautiful. So let me introduce a clinical case. So this was a patient that I treated very recently, and we'd actually, failing upper dentition, we decided to take out the teeth and let the mucosa heal and mature. And here you can see, first of all, I'm just outlining the right maxillary sinus, the medial wall. Here in yellow, you can see as the line has been drawing, this is an anatomical structure. This is the canalis suniosus. And in this canal, we have the anterior superior alveolar nerve. So ideally, if I can, I don't want to be putting my implant through here. So on the right side, I've planned to place an implant through the crest, through the sinus, and then engaging that nice bit of cortical bone to get stability with the apex of the dental implant. So here's the pre-op situation. As I said, you can see recent extractions, the mucosa is healed. And I always like, when I'm doing trans-sinus or zygoma surgery, I like to work with healthy mucosa and healed sites. Certainly in my hands, I get better predictability and I'm just more comfortable, especially when I'm working close or involving the sinus. So we started off the surgery here, and I started off not in zygoma surgery, trans-sinus surgery, I do sectional flaps instead of one full flap. So we started on the right side, exposed up to the nasal floor, the lateral part of the nose, midline incision, raised a palatal flap. And then in the next image, you can see I'm using just one of my sinus instruments to start to lift up the nasal mucosa. Now, the nasal mucosa is quite robust. It can be anywhere from 0.5 to 4 millimeters in thickness. And it's quite straightforward to raise that. And it is important that I raise the nasal mucosa just to protect it. And then I'm very much use a very intricate instrument, a pencil. I draw on the bone. So I know the path that I'm trying to take my dental implant along. And then we do a bit of ridge reduction for restorative space and creating a nice flat platform to allow implant placement. And you can see beautifully here the angulation, the direction I'm going. And very much, yes, all these patients have a CBCT. I've planned digitally how I'm going to carry out my surgery, but there's a lot of anatomical driven surgery here. I like to see where I'm going with my drill, the start point and the end point. At heart, I'm a surgeon. And then I utilize this instrument, it's disposable safe scraper. So I have visualized exactly where the anterior wall of the right maxillary sinus is. And I utilize a safe scraper to, one, collect autogenous bone, and two, to start to access the maxillary sinus just anterior to the medial wall. And you can see I've collected a lot of autogenous bone here. And if I wanted to, I could utilize this to put back into the sinus, to graft around the implant, or utilize it somewhere else in the surgery. In the next image here, you can see the direction of the drilling. The sinus has been lifted out the way, and you can just see the apex. And I want to visualize the apex of the implant piercing through. And so you follow a stepwise protocol, often a degree of under preparation, and prepare. As you can see, we get bicortical stability. And here is the GM long, and I think this is a 20 millimeter implant. And here's just an image of me preparing to place the implant. So everything's set in place. And then I've got a small video. So nice and gently, controlled fashion, I'm inserting the implant, expanding the bone to a degree because I'm under preparing, letting the bone relax. And then just at the end, as the apex gets to the base of the nose, we get the beep. I love that sound. You hear the beep, and I know I've got the torque, the minimum torque that I'm wanting to immediately load. And this was at that point, and then we put the implant to the correct position depth-wise, and then complete the rest of the full arch implant treatment. We placed 4 implants here, happy with everything, and then naturally we're angle correcting, and here's a 30-degree multi-unit angle correction just to show you the restorative position. And I've taken another angle here where you can see where the restorative screw axis hole is going to be, and I'm very happy with that. That's coming out between, it's probably at the second bicuspid within the restorative envelope, very pleased. And here's the final x-ray on the day of surgery. And actually on the left side, I've placed a long implant as well, although it's not gone trans-sinus, but I've gone long to get bicortical fixation at the base of the nose to get the stability to deliver the patient teeth in a day. So just to touch upon, like any implant surgery, there are complications, but specific to trans-sinus that you need to be aware of. Damage to associated structures, so the nasal mucosa, the nasolacrimal duct, canalis sinuosus, as I illustrated in one of the previous images. And also you need to be aware of protruding the implant too far into the nasal cavity. So a millimeter and a half, I'm comfortable with, but any more than that, I would be cautious because you can get problems and potential nasal discharge. So now moving along and introducing pterygoid implants, really first introduced by Telasny in 1989, been around for a long, long time. So this is an implant inserted at the maxillary tuberosity, passing the pyramidal process of the palatine bone and engaging the pterygoid process of the sphenoid bone. And this is a comment that I picked up a number of years ago when I was at a lecture, and I can't remember the source, but it stuck with me. And pterygoid implant placement is simple surgery in a complex territory. And when I teach this, when I talk about this, this is always at the top of my mind. It is simple surgery, but we're working in a complex territory, and it's important to respect that. The complexity comes in the fact that it's often a blind nature to this procedure, and there's always an emphasis on feel. And like trans-sinus as well as pterygoid, this implant technique is a stepwise development in your full arch journey. So what are the ideal features of a pterygoid implant? Well, very much like a trans-sinus, tapered. Again, we want an aggressive thread design. Lengthwise, I'm placing implants that are 15 to 18 millimeters in length, and you want the options of various diameters, and most importantly, prosthetic flexibility. So very much like trans-sinus, this is aligned with trans-sinus and pterygoid. The ideal implant design is similar to both. So let's look at a clinical case. And again, whenever I'm doing anything more complex, I like to do one side at a time, very much sectional, so I can manage the patient. Often these patients are being managed under local anesthetic with single agent sedation. And so I've completed the right side of the surgery and I'm moving along to the left. And I'm very protocol driven as a surgeon, and I have a set way of doing things, and I don't like to digress. So I did the right surgery, and if I'm placing pterygoid implants, I always like to place a pterygoid implant first, and I always start on the right side. And if I'm doing a left pterygoid, then I'll place the left pterygoid, and I do it in sectional flaps. And so in this case, we've moved from the right side. We didn't place a pterygoid on the right side. We've gone to the left side, and we start with the left pterygoid. And so first we need to talk a little bit about surgical flap design. So we do a sectional flap here, as illustrated with the dotted lines. Then here's a view of the pre-op CBCT, a slice. You can see a particularly challenging case again. On the right tuberosity region, there's an impacted wisdom tooth. On the left zone, the left side of zone 1 and 2, you've got two, not one, two impacted teeth, a canine and a premolar. And then on the left side, I'm planning to place a pterygoid implant, which is handicapped with the fact that there's a tooth there to take out as well before I manage to place a pterygoid implant. Patients are very much led by the clinician or the surgeon. And for some patients, I could give them immediate load, but it would need zygomas. But I could also give them a full arch fixed restoration, but it would be a delayed approach, and it's avoiding zygomas. Now, it's that discussion with a patient. Do they want to go ahead with zygomatic treatment and then delivering predictability and treatment in teeth in a day? Or are they happy taking a more stepwise approach, going for conventional implants and allowing zygomatic implants to be kept as a reserve for future revision surgery? So to answer the question, it's very much stepwise. If I can avoid zygomas, absolutely. Then, yeah, conventionally, it's a very traditional sort of neo-arch, two straight, two angle to avoid the sinus. I will utilize pterygoid implants in younger patients or patients with wide or wide smiles, and some patients where are younger and I want to rehabilitate with 6 implants rather than 4, and then I work up the ladder just like that. When it comes to trans-sinus, well, trans-sinus implants are very much limited to patients that have the anatomy to allow you to do that, and that's the anatomy where you get anterior pneumatization of the maxillary sinus up towards the canine root. So these types of cases don't walk into the office every day. It's not that common in my experience, and so it's one to have available in the armamentarium, but it's not one that I do very commonly, to be honest. Well, and that's just because the anatomy doesn't allow it.
Oh, thank you very much. And we share exactly, I mean, from here we share the same opinion at Lapel. That's really nice to hear it, especially when we have a situation like now where we are talking here. In the meantime, the organization team was fixing the sound, and I believe that Dr. Daniela has a very good news for us right now.
Oh, good.
So, Dr. Verham, we fixed the problem with the audio. Now everyone can hear you in all the 7 languages that we are transmitting. So if you want to share again your screen and continue your lecture. I'm so sorry about this, but right now everything is fixed.
Wonderful. Let me just share. So just confirm that you can see the screen.
Yes.
Okay, good. So this was the final X-ray. So you remember this a few minutes ago, I was just sharing the placement of a pterygoid implant on the left side. And so here the implant's been placed, multi-unit has been inserted, and we've achieved stability. And this was the X-ray on the day of surgery following immediate load. So we got conventional implants anteriorly, but you will remember that there were impacted teeth in the left side, in the incisor region and in the bicuspid region. And of those of you that do full arch immediate load surgery, that's a real curveball in the procedure and challenging to get stability when there is not a lot of bone, and we've had to remove quite a bit of bone to get these impacted teeth out. So I've gone for, I think, probably 13 millimeter implants here. I've engaged the nasal floor. I got stability of maybe 30, 25, 30, but the added bonus and where the pterygoid implant really comes in to its own is that I was able to place the pterygoid implant, get stability of at least 50 newtons centimeters, and then do and deliver a cross-arch stabilization and interim prosthesis. And my colleague before me spoke beautifully about the importance of the interim prosthesis, screw retained, no cantilevers, cross-arch stabilized, everything splinted together. And then this gives me confidence that we can restore this patient adequately and deliver them teeth in a day and a long-term fixed solution of an upper rehabilitation. And just coming to the end, just briefly touch on complications specific to pterygoid implants, bleeding. There's a lot of important anatomy up in that region that you need to be aware of. Potential risk of loss of an implant into the maxillary sinus if you are misdirected with the osteotomy preparation, working with particularly soft bone, working with a tapered implant, aggressive design. The implant will go wherever it wants to unless you are really controlled with your and precise with your placement and direction. So, and that this is a risk that you can lose the implant in the sinus. Something a bit more serious is losing the implant into the infratemporal fossa. And something that can happen quite commonly, especially when you start doing this, is and getting the preparation of the osteotomy correct, you can fracture the tuberosity or the pterygoid plate. So just to summarize, and just some take-home messages. The use of the long implants from GM, Neodent, may avoid more complex solutions, reducing morbidity and expediting the treatment process for our patients. If we think back to the father of implant dentistry, P.I. Branemark, and what he stood for and what he wanted to deliver, then this was it. The Neodent GM Helix Long complements the standard implant system for achieving immediate load protocols and fixed full arch rehabilitation. And this is the key here. It's designed to bring predictability to manage these atrophic maxillary cases. So I just want to thank you again for the invite. Thank you for your kind attention. And over to you.